Good evening, everyone, and we welcome you all today for the panel discussion on management of renal cell carcinoma with comprehensive genomic profiling approach. South Asia perspective is the discussion theme today. The reason being, we have treating medical oncologists and surgical oncologists from India, Nepal, Philippines, Bangladesh, Uzbekistan, and Abu Dhabi. So it covers the Southeast Asia as well as the Middle East. So we are having Dr. Raj Nagarkar, who is the managing director and the chief robotic surgical oncologist with an extensive experience of 3 decades. He is the founder director of HCG Manavata Cancer Center at Nashik in India. And Dr. Raj will be moderating the entire session, discussing several cases and how different countries are experiencing sharing their experiences on the treatment and management of renal cell carcinoma, and how molecular genetics can add value to the treatment approaches today. And in our panelist, we have Dr. Pankaj Barman from Nepal, Dr. Nicasio Radovan from Philippines, Dr. Mohammed Rafiqul Islam from Bangladesh, and Dr. Shruti from India, Dr. Makhsud Mallaev from Uzbekistan, and Dr. Mudashir Ahmed from Abu Dhabi. So with not much of a delay, I would like to hand over the stage to Dr. Raj sir. Kindly take over and start the moderation. Thank you, sir, for all of you for being here, and we look forward to this exciting discussion today.
Thank you, Dr. Vidya, and thank you, Forbes. It is a wonderful opportunity to connect with such eminent medical oncologists across South Asia. And as you rightly mentioned, it's like we are all those separated by few boundaries, but when it comes as doctors and patients, all of us share similar type of challenges on a daily basis. And I think all of us are in the same business of bringing back smiles on our patients' faces, which is there. So it is a wonderful opportunity to have such esteemed panelists with me for this session. And in order to make it more of a interactive session and rather than just a theoretical discussion, I have tried to divide into 4 case-based scenarios as to how renal cell carcinoma patient presents to us. And these are all real life scenarios. All the 4 patients are those which we have treated. Me and Dr. Shruti, my colleague who is a medical oncologist at HCG Manavata, we have treated. So it's like, it will be good. There are no hypothetical cases which have been just thought about. So let us start with the, So in fact, friends, all of us are aware about renal cell carcinoma and its epidemiology. It's a disease which arises mainly from the tubules in the kidney. And the signs of renal carcinoma mainly include hematuria, a lump in the abdomen, and there are instances where the patients present after the disease has already metastasized to the other parts of the body. And usual radiological and pathological tests for diagnosis for kidney-related issues are also taken up over there, along with factors, tests like PET CT scan or a bone scan to find out the metastatic status. There is a rapid rise in the kidney cancer cases worldwide, and it is expected to be one of the fastest increasing cancers over the next 20 years. What is fueling renal cell carcinoma? As we know that smoking, obesity, hypertension, metabolic imbalance, renal diseases, alcohol, other comorbidities, along with the use of various analgesics are responsible for converting that normal gene into a mutated gene. Histological types of renal cell carcinomas, if you look at it, most of the renal cell carcinomas belong to the clear cell variant of renal cell carcinomas, followed by the papillary renal cell carcinoma, the chromophobe renal cell carcinoma, and few are renal tumors which are though not malignant in the true form as far as having a potential to metastasize, like oncocytomas, angiomyolipomas, cystic nephroma, and even renal cysts which are there. As we know that 5-year survival for benign diseases has to be good, and oncocytoma is almost 80 to 90%, as well as the papillary renal cell carcinoma is 70 to 85%, and clear cell carcinomas, we tend to have a 5-year survival of averaging 50 to 70%. But obviously, this survival is also largely dependent on the stage at diagnosis. For those patients who are localized disease, almost 65% of them tend to have a 5-year survival. And as you happen to go to the metastatic, regional to metastatic, the survival does drop down. But still, thanks to breakthroughs in the management options and the diagnostic modalities available, even in metastatic disease, we still happen to see a 16% of 5-year survival rate, which is definitely promising as compared to the other solid tumors which we come across, though this 16% should be made a little more in the years to come. If you look at the Cancer Genome Atlas, a comprehensive molecular characterization, we know that there is varied types of genetic aberrations which are noticed from the clear cell to the chromophobe and the papillary cell carcinomas. This DNA hypermethylation is also responsible for prognosticating the tumors which is there. Now, cancer genomic pathways are used in the management of various renal cell carcinomas. Dr. Shruti, can you just guide our audience as to... Okay, I think Dr. Shruti is busy with something, but these cancer genomic pathways in the management of RCCs, these tumor signatures, TME, and the genomic profiling. Yeah, Shruti.
Yes.
Dr.
So,
yeah.
The cancer genomic profiling is the newest paradigm on the treatment of management of metastatic cancers. But as of now, for renal cell carcinomas, NGS findings are not very actionable. And irrespective of the TNB, the microsatellite status, or the genomic LOH, which usually guide us towards treatment of immunotherapy in a metastatic setting, for RCC, it is irrespective of that. So there are some studies which are ongoing, which are aiming at selecting patients for immunotherapy on the basis of these tests. But as of now, the results are not out. So we are waiting for a couple of studies which are ongoing, and let's see what it holds true. But for gastric tumors, especially, we have patients on immunotherapy based on the tumor mutation burden, even though the PD-L1 is negative, and they respond wonderfully to immunotherapy. So it's a boon to certain group of patients, but as of now for RCC, there is little or no information as of now.
Okay, thank you, Dr. Shruti. And I'm sure that in the forthcoming days, we are definitely going to have some options available where, based on these molecular pathways, we will be able to decide the treatment for the patients, particularly with the available IOs also. And future treatments, the assessing different trials based on the genomic markers, whether TKIs or mTOR inhibitors, double IO or IO with VEGF inhibitors, all these things, there are quite a few studies and trials going on, hoping that in the near future, we will have certain data, more comprehensive data available. If you look at the evolution in the therapeutic and genomic landscape in renal cell carcinoma, from 1992 till date, there are a wide era of options available. We have definitely moved away from the era where we are just talking about IL-2 to sorafenib, and now we have all the Pembro, Lenvo options available. So with this background about what has been the epidemiology as well as the therapeutic landscape available in the management of renal cell carcinoma, I have tried to divide the entire discussion in 4 case-based scenarios. And I would request my esteemed panelists, I will put forward the questions as to how they feel they would have managed this patient best in their individual clinical scenarios. Case 1, a 43 years old young gentleman, ECOG status 1. He presented with history of intermittent hematuria, did not have any medical or surgical history, and clinical evaluation also did not show any evidence of mass palpable. He did not give any history of mass. Clinical evaluation, there was a palpable mass about 7 by 7 centimeter in the right lumbar region, no hepatosplenomegaly, no varicocele. He was investigated with hematological investigations. All of them were fairly within normal range, and ultrasonography which was done showed that it was a right renal mass 10 by 5 centimeter, and it was a well-defined partially exophytic mass. There was IVC and renal vein appeared normal. So based on ultrasound evaluation, it was thought as a renal cell carcinoma, and he was referred to a cancer center with this basic investigations. So I would like Dr. Makhsud, Honorable Medical Oncologist from Uzbekistan, like with this type of clinical profile, if a patient reaches you, what would be the way in which you would investigate this patient further? Dr. Makhsud? Or if Dr. Rafiq is around, can he please take this question? Dr. Rafiq?
Dr. Rafiq is muted, I guess.
Okay, sorry. Yeah. Can you hear me?
Yeah, yes.
Okay, thank you. This is a very common presentation of the RCC in my setup. I'm working in the Bangladesh National Institute of Cancer Research and Hospital. After getting this scenario, we'll just go forward for the next level of the investigation, that is a CT scan of the whole abdomen and other scan, like for the the staging purposes. Is there any metastasis site or not? So in that scenario, I'll go for the next the CT scan of the whole abdomen.
Okay, so CT scan of the abdomen and pelvis. Dr. Rafiq, do you also advise a CT scan of the thorax and bone scan at this stage? Or you... Okay.
No. Actually, in that scenario, I'll just go for the first of all the CT scan of the whole abdomen and the pelvis to almost the CT scan and can the diagnosis almost 90%, 99% sure regarding this is a RCC or not. If I can assure the RCC, and then we can go for the further the staging purposes, the other CT scan and chest and thorax and others.
Right. Thank you, Dr. Rafiq. As you rightly said, this gentleman, we did perform a CT scan of the abdomen and pelvis, and the CT scan picked up a 71 by 78 mm lesion involving the right upper pole of the kidney. Radiologically, it appeared as if the fat planes are lost with the liver and the diaphragm, but there was no evidence of any major nodes, or CT thorax and bone scan also appeared to be normal. So with this,
Hello.
Dr. Raj, are you there?
I think we seem to have lost him.
Okay, yes.
CT scans.
Dr.
Raj, I think your connection was lost in between. Can you just come again and repeat the question?
Yeah. So basically, my question was to Dr. Nicasio that after the CT scan is done, and we've noted the CT scan findings, what would be the next way of investigation this patient and management of this patient? What would be your advice?
Good evening, everyone. I'm a medical oncologist from the Philippines, Dr. Nick Radovan. So based on the information that we were given, 7 centimeter, is that 7 centimeter renal mass?
Yeah, that's right. Yeah.
Without any lymph nodes and
no nodes seen. Yeah.
Yeah, and it seems to be the fat planes are maintained with the liver and diaphragm. So this can be a T3, T2A or T2B tumor. So
yes.
Yeah. So for now, the primary impression my primary impression would be renal mass to consider primary renal malignancy.
Okay.
With its location on the pole of the kidney and not in the central, a differential of urothelial mass can be considered, but it will be less likely as it usually presents in the middle of the kidney.
Okay.
And for now, the stage can be based on the CT scan and ultrasound to be stage 2 for 2A tumor, T2B tumor, yeah.
Right. Any role of biopsy at this stage?
Okay. Well, generally for tumors of this mass, usually we go head straight for resection, either partial nephrectomy or total nephrectomy, radical nephrectomy.
Okay, fine. Yeah, so there is no role of biopsy as such. And well, though I have all medical oncology colleagues on the panel, but still, given once we have decided for the surgery, as a medical oncologist, if as part of discussion with the MDT, what would be your preferred choice of surgery? Lap versus robotic versus open? Dr. Mudassir?
So,
yes, Dr. Mudassir. I know I'm asking a surgical question to a medical oncologist, but still.
Yeah, it's a surgical question. So I think you will be able to tell us more about this. So is the laparoscopy there enough? Is the robotic there enough? Because I think the robotics is now taking over in every specialty. And the outcomes have been really very comparable and with very minimal toxicities and the post-op care and post-op recovery. So I would like to hear from you, what is the stage now for robotics?
Yeah, Dr. Mudassir rightly said. I think this is a patient where it should be straightforward, minimal invasive radical nephrectomy. There is no role of laparoscopic or robotic. It's, I think, the surgeon's choice and availability of equipment. But someone like me who has got both the options available as part of my surgical armamentarium, laparoscopy as well as robotic, I would definitely
I think, sir, there is some there's some delay in the voice. I don't know. Is it only I am feeling it? Or
robotic?
Yeah.
Same here.
Dr. Raj?
Actually,
it is
I
better
think
for
the
the
problem.
patient. The pain is less. Okay. From my side, it is looking absolutely comfortable. But okay, do you want me to switch this thing?
Sir, actually there is some problem with your internet connection. Probably it is not. If you can just switch off your video, maybe maybe that will help.
Okay.
Yeah.
Kindly check. Is it better?
Yeah. Now it is okay. Yeah. In between,
okay.
your connection is completely good, but sometimes it just gets off.
Okay, fine. Okay, fine. So I think I would come back to that. As far as the surgical choice is concerned, now we are moved to an era of minimal invasive surgery as far as radical nephrectomy is concerned, and it is, though not superior as compared to between lap and robotic, but definitely there is a non-inferiority study which has been proved as far as the radicality of excision is concerned and the lymph node yield is concerned. But robotic is definitely better for the patient wherever the technology is available. So this patient, he underwent a robotic right radical nephrectomy, And the final histopath report turned out to be a clear cell renal cell carcinoma. The margins were free. There was no perinephric fat infiltration. Nodes were free. T size was more than 7 centimeter. It was a grade 3 tumor. Final stage was PT2, PN0, PM0. So based on the PT2N0 status, what is the role of adjuvant treatment in this particular patient? Dr. Barman, can we have your comment, please?
Sure. So I think in this patient, there is no role of adjuvant treatment because it is a grade 3 tumor. The indication of adjuvant treatment in RCC is like clear cell RCC with grade 4 and features of sarcomatoid features. So in this patient, I'd like to keep the patient on surveillance.
Dr. Barman, what would be your surveillance advice for this patient?
Surveillance advice would be every 3 monthly follow-up with routine, we can scan ultrasonographically, chest X-ray every 3 months.
Okay, fine. Yeah.
Dr. Raj, can I add something to this?
Yes, please.
Actually, there is some other options to decide whether the adjuvant treatment is necessary or not. There is some guidelines, the SMO guidelines. They are talking about the SSI engine scoring system. So SSI engine scoring system, if the score, the patient, if having the lowest score, no need to the adjuvant therapy. But if the patient having the intermediate risk or the high risk group, in that case, there is some role of the, the adjuvant therapy. And according to the SSIGN score, they have 6 tiers like pathological T staging, regional lymph node, metastatic category. All are the 0, but the tumor size is 2, T2, and nuclear grade, that is 3, that points 1, and we don't know regarding what about the necrosis at the HPR, that is histopathology report. So if the patient having scored 3 or more than 3 up to 5, then patient will categorize as the intermediate risk group. If the patient is recognized as the intermediate risk group, in that case, the patient will be needed for the the adjuvant therapy. So I think this scoring system, it is already established in SMO guideline. This is not the mentioning in the NCCN guideline, but the SMO guideline, the European Society of Medical Oncology, they are proving that this SSIGN scoring system is very fruitful for the patient. That is I just sharing my experience with this thing regarding this patient.
Okay, thank you, Dr. Rafiq. And I think as of now, based on the NCCN guidelines, this particular patient who falls into the stage 2 category, it is either a clinical trial or a surveillance, and the role of pembrolizumab, as Dr. Barman rightly mentioned, it's only for grade 4 tumors or those with sarcomatoid features. But obviously there is now these ESMO guidelines, which should be considered for those patients who are falling into the intermediate or high risk category.
Yes.
Moving on to the second case, a 55 years old lady, ECOG status 1, was a known case of carcinoma of the breast. Operated 3 years ago. It was a ERPR positive as a luminal A-type tumor, T3N1, and she had undergone MRM followed by adjuvant chemo and RT, and was on regular follow-up on oral tamoxifen. She came with a history of a single episode of hematuria, and per abdominal examination picked up a large left lumbar mass which was palpable. Ultrasonography was done, which picked up a 54 by 53 millimeter lesion involving the upper polar region and loss of corticomedullary differentiation. Renal vein, there was a focal thrombosis, and there also was a large 36 by 27 millimeter node in the left para-aortic region. So 55 years old lady, known case of carcinoma breast, on hormonal therapy. She comes after 3 years during routine follow-up with a renal mass with a large para-aortic node. Dr. Shruti, what would be your first thought of this radiological finding, and how would you evaluate the patient? Dr. Shruti, not able to hear you. Or
Dr. Shruti is muted, I think.
Is audible? Yeah. Yeah. I think I'd lost in between. Yeah. Can Dr. Nicasio take this question as to with this radiological findings, how would you investigate the patient?
Yeah, thank you. So for this patient, based on the ultrasound, we have a 5 centimeter mass in the upper pole with seeming loss of corticomedullary differentiation with enlarged node, the para-aortic level. This can, our primary impression once again is renal mass to consider RCC stage 3 with a regional node. So it would be good if we can visualize the kidney better with CT scan, ideally with contrast if renal function permits. That would be my next step.
Yeah. Only because this lady has already undergone a surgery for carcinoma of the breast, and we thought about evaluating her not only from a renal point of view, but also we considered for a whole body PET CT scan was done, and the PET scan did not show anything in this chest wall region. I think moment I start my video, this becomes unstable. I'll just yeah. So yeah, I think my video does not permit it's better. Yeah. So we considered for PET scan only because whether it was a part of a metastatic disease or a second primary which we are looking into, and PET scan did not show any evidence of disease in the chest wall or in the thorax or in the skeletal region. However, there was a large mass involving the entire left kidney, almost 94 mm, and there was loss of fat planes with the left crux of diaphragm. The left renal vein appeared encased by the mass. There was an extension of a thrombus involving the left renal vein going into the IVC. There were large nodes in the para-aortic region also. So this was the PET scan image. If you look at a huge mass involving the entire kidney and nodes which was encasing the vein and the thrombus to the IVC also. So what would be the line of management in this particular patient? Can we have Dr. Mudassir?
So in this patient, there is a history of breast cancer. It looks like that was T2 and N1, the endocrine receptor positive and HER2 negative breast cancer, and she has already completed treatment probably some 3 years back, and now she's on tamoxifen. So the PET CT scan does not show any metastasis anywhere. So we probably cannot ascribe it to the breast cancer. So because, to me, from so far, it looks like that it is actually a primary renal cell carcinoma or the primary kidney pathology with a local para-aortic lymph node. So I would suggest that I think we go ahead with a complete completion of the to go for the nephrectomy rather than going for biopsy first and then going for the further.
Okay. Yeah. Thank you, Dr. Mudassir. And as you rightly mentioned, that this particular patient, we posted her for a open left radical nephrectomy with lymphadenectomy and a thrombectomy. Here, there was no role of any minimal invasive procedure. And a final HP turned out to be a papillary renal cell carcinoma grade 2 with extensive tumor emboli, pelvic alveolar system involved, renal vein emboli was present. The vascular cut margin of the cava came positive because of the, although the tumor thrombus was removed, but probably there was a microscopic tumor infiltration into the caval wall. 7 out of 17 hilar nodes were positive. There was perinephric fat involvement also present. IHC proved to be a CD10 positive, MAXCR positive, PAX8 positive, suggestive of a clear cell variant of renal cell carcinoma. So with this histopathology, what would be the, and IHC report, what would be the role of adjuvant therapy in this particular patient? Can we have Dr. Mudassir over here?
So this patient is slightly different from the previous patient. Previous patient was T2 and N0. It was that was Furman grade 2, I think. This is a node positive disease, and it is, I think, PT3. Is it?
That PT3.
Yeah. So PT3 with node positive. I think this patient, in this patient, we can actually discuss the possibility of adjuvant. Adjuvant pembrolizumab based on the keynote study.
Okay, fine. So this particular patient, as you rightly mentioned, adjuvant pembrolizumab is the best option available, and where patient, if financial concerns are there, we also do think about adjuvant sunitinib if immunotherapy is not feasible in our particular scenarios. Presently, this patient is on adjuvant pembrolizumab every 3 weekly. She has already completed 3 doses. Now, any role of adjuvant radiation in this particular patient, particularly in the backdrop of a renal vein margin being positive, IVC margin being positive?
Is this question to me?
Yes, Dr. Mudassir, you can take that.
So, traditionally the renal cell carcinomas are not supposed to be, very radiosensitive tumors. Though we sometimes use in certain scenarios, we can use, the high dose chemotherapy, high dose radiotherapy like the SBRT, etc. But in this scenario, if the margin is positive, it is, if we are not giving any adjuvant, I would suggest actually just observation. There is no role of radiation therapy to compensate for a, for a positive margin.
Okay, thank you, Dr. Mudassir. Thank you.
Can I add on something here, Dr. Raj?
Yes, please.
Yeah, so I think in this patient, I'll be very keen on doing a next generation sequencing because of the history of carcinoma of breast and a papillary RCC. She could be fitting into a Cowden syndrome, and we can pick up some mutations like P10 mutation and other biomarkers. If you can find P10 mutation, those patients can, they may benefit with mTOR inhibitor rather than pembrolizumab.
Okay. Right. Thank you, doctor. Moving on to the third patient, a 35 years old young male, ECOG1 status, who presented with pain in the upper abdomen, breathlessness and weakness about a month. And he had history of COVID pneumonia 15 days back. So with the history of post-COVID pneumonia and breathlessness with upper abdominal pain, he reached out to a physician and subsequently to a cardiologist. And when he was evaluated and found to be having bilateral pulmonary thromboemboli on a CT angiogram. A 2D echo, which was done, showed LVF of 48% with anteroseptal and inferoseptal hypokinesia. And the CT thorax, which was done incidentally, that also picked up the USG abdomen pelvis, which was done, it picked up a mass which was involving the right kidney. And the mass was indenting on the adjacent liver with maintained fat planes extending into the IVC and renal vein. Hilar and paracaval lymphadenopathy was present. PET CT scan was done for this particular patient, considering the CT angio showing pulmonary thromboemboli. And the PET scan showed a large mass involving the right kidney, obscuring the renal pelvis and extending to the PUJ and upper ureter. The mass was closely abetting and infiltrating the psoas muscle. There was a thrombus involving the entire right renal vein, extending into entire IVC, sparing mid and distal portion of intrahepatic IVC. There was lymphadenopathy was present. The intrathoracic part, there was both lung metastasis along with thromboemboli could be made out in the main pulmonary artery which was there. So we were looking at a scenario where this gentleman who reached out to a physician for breathlessness and vague abdominal pain was actually having a metastatic RCC along with the pulmonary thromboemboli. These pulmonary thromboemboli, 2 scenarios, it could be either post-COVID or second part were, these were tumor thromboemboli with which he presented. So 35 years old gentleman in this scenario, if he presents, how do you manage this particular patient? Dr. Shruti, you would like to take this question, please? Dr. Shruti?
Dr. Shruti, you are muted. We don't know whether you are there or not.
Okay. If not Dr. Shruti, I would request Dr. Makhsud or Dr. Rafiq. Anyone can take that.
Thank you. This is a very, I think this is a metastatic disease, metastatic
Right.
RCC. So in that case, we have two options. Is that patients, after selecting the patients and after assessing the patients, if the patient having very good performance status or patient having the solitary and oligometastasis and patient life expectancy more than 2 years, and if the patient having the histopathology report at the low Farham grade, and if the complete resection is possible, in that case, we can go for the cytoreductive surgery. If the patient completed all the criteria for this the surgery, then go for the surgery. If not fulfill the criteria of these things, then I think we should go for the next palliative management like Pembro or others options which are available in our setup.
Okay. Thank you, Dr. Rafiq. In fact, for the benefit of all the non-oncologist audience who are part of this wonderful webinar, I think Dr. Rafiq has given a very nice way of putting it, that even in those patients who are metastatic, see, normally the perception is if the tumor has spread outside its primary organ and in the regional spread is there, then metastatic disease there is no role of surgery. However, there are few exceptions, and RCC happens to be one of them, that in case of oligometastasis or wherever there is a low tumor burden metastatic disease, still you can try and achieve a good long-term survival benefit by surgical resections, either of the primary along with the metastatectomy or by using radiotherapy like SBRT, other options which are there. So even in stage 4 patient where there are potentially surgically resectable primary, we should consider for a cytoreductive surgery. This particular...
Sorry, I'd also like to add that it would also be a good idea if we counsel the patient regarding gene testing, because the patient contracted RCC at a young age. There is a chance that it may be, he may be carrying familial mutated genes that predispose to RCC.
Okay.
So referral to geneticist is recommended.
Okay. Yeah. Thank you, Dr. Nicasio. And as you said, that because it's a young patient, it's not only about talking about the tumor burden, but also trying to find out whether this is some familial genetic mutation which has predisposed him to develop a renal cell malignancy at such a young age. The treatment modalities were discussed with the patient regarding the role of nephrectomy with thrombectomy, but due to the pulmonary thromboemboli and the cardiac issues and considering the high anesthesia risk, the patient was planned for systemic therapy since he was not fit for anesthesia point of view. Since he was planned for a systemic therapy, non-surgical therapy, we planned to do a biopsy, and the biopsy turned out to be a clear cell carcinoma, Ferman grade 3. And accordingly, the patient was counseled regarding the disease and the intent of therapy as a metastatic intent. And he was discussed in the MDT, and the patient was offered treatment options. So Dr. Shruti, I think you are back. So what would be the treatment options you would offer to a patient in this scenario as a metastatic RCC along with pulmonary thromboemboli?
So the good thing for the treatment options for RCC is that immunotherapy options coupled with VEGF therapy or VEGF TKI are very well tolerated. So cardiac issues or thromboembolism issues are not the major problem there. So I would definitely counsel the patient for a combination of TKI with immunotherapy, either axitinib pembrolizumab or lenvatinib with pembrolizumab. And since the tumor burden is very high, because those combinations bring the most rapid responses and are quite well tolerated. I would usually secure a treatment like cabozantinib for the second line setting in this case. So my usual preferred choices are lenvatinib pembro or axitinib pembro, or even for that matter axitinib with avelumab.
Yeah, but for those patients, not all patients are going to be affording as far as immunos are concerned. For the patient who is not affording, because we started the discussion that we are talking about South Asia region, and South Asia region almost has similar type of challenges in the clinical portfolio and clinical scenario. Secondly, I would like to ask Dr. Rafiq again over here, that we have this patient where the biopsy is clear cell carcinoma. It's a Fuhrmann grade 3, which was reported. So would you, Dr. Shruti has enumerated the options which she is going to offer. Would you like to do any further investigations like a IHC or anything at this stage, or you would start the treatment immediately on this? Dr. Rafiq?
Definitely we will go for the IHC because of, there is always some dilemma regarding the histopathology. So first of all, we go for the immunohistochemistry if there is any changes of the diagnosis or not. Because this is already, Dr. said that the very young patients, so they have presented with the very aggressive disease. So is there any options for or is there any diagnostic dilemma? We should avoid this diagnostic dilemma too. So we have go for the next investigation, that is the immunohistochemistry, to confirm the biopsy report, that is that coming from the clear cell or not.
Okay, fine. So this patient was discussed in the MDT and joint clinic. He was given the option first of surgical resection, but because of high cardiac risk, it was not permitted by the anesthetist also. He was given an option of IO along with VEGF and TKI combination, but unfortunately, financial constraints did not permit him in going for pembrolizumab, and hence he was started on a lenvatinib with everolimus combination. After 2 months of a lenvatinib and everolimus combination, when a repeat PET scan which was done, he showed that the PET scan showed that the tumor had progressed locally, while his intrathoracic disease, both the tumor thromboemboli as well as the lung nodules, the metastatic lung nodules, both of them, the thromboemboli obviously came down because he was on blood thinning agents, and the tumor which was there, the nodules which were there, they also showed a partial regression. So what would be the option or advice for this patient at this particular stage? Dr. Nicasio or Dr. Barman? Dr. Barman is, I'm sorry, I've not come to you for some time.
Okay. So I think this combination is correct if it is a clear cell RCC, lenva plus everolimus, but since there is progression now, so if he is surgically fit enough to undergo a surgery, I would like to advise him for surgery at this point.
Okay.
And also like to do an IHC.
Right, thank you. In fact, the similar thing was planned and discussed with the family, and we went ahead doing a right radical nephrectomy with IVC thrombectomy and with the radical lymphadenectomy. And the surprising part which came out, that the HP, which showed a round cell tumor, the capsule was involved, perinephric fat was involved, the ureteric cut margins were free, but all the 10 nodes which were removed, see, when he was diagnosed, the PET scan had showed a lot of para-aortic nodes, hilar nodes, and the repeat PET scan also showed a progression, but all the 10 nodes which were removed were free from metastasis. It was an N0 disease. And since it turned out to be a clinical and a pathological surprise as a round cell tumor, IHC which was done proved it to be a PNET. So a PNET, yes, Dr. Shruti.
I remember for this case, we did go back to the initial biopsy, and our pathologist was sure that the histopathology as well as the IHC was pointing towards a renal cell carcinoma. So our hypothesis is that maybe the patient had a small focus of an RCC and a disease which was a PNET, but maybe a dual malignancy or something like that, because even after this report, when they went back to the original biopsy and reviewed it again in the light of present report, they were unable to rule out a clear cell RCC, which is hard to confuse with any other pathology. So usually it's a very sort of a favorite diagnosis for the pathologist. It's very easy to make out the histology on the slides. So
Right.
I guess there could be many a times patients may have an asymptomatic focus of an RCC in their kidneys for many years that is known. Especially for RCC, it sometimes regresses on its own as well, because it's a tumor which is dependent on growth factors, vascular growth factors. So I feel that it could be something like that. And there was another pathology which was about to become a predominant pathology once the patient was started on this treatment. So
Yes, thank you, Dr. Shruti. In fact, you have really pointed out, and there are various publications available and various case reports available about mixed histologies in RCC. Because in this particular patient, as you pointed out, that patient had a favorable response for lenvatinib with everolimus combination as far as the nodes were concerned, as far as the intrathoracic, the lung metastasis and pleural base nodules were concerned. But patient had progressed as far as the local disease was concerned. So going back, there are, it is not very uncommon to see mixed histologies, though they are rare, but they should not be shunned out completely. And in case a patient has progressed or they're showing a mixed response, there is no harm in always going back, re-evaluating the original slides and offering him some other modality of therapy like surgery in this particular patient, which we had offered.
So I have actually an observation from this. So I agree with you that these two types of tumors can be mixed histology. It's well known, and the biopsy, when we do a core biopsy, there's always a problem with core biopsy that we may only take a part of tumor, and the tumor may be heterogeneous. So that is there. So the other thing is that should we do the immunohistochemistry, on the biopsy or not? That was actually, because, in the retrospect, we can now say that, we probably were wrong, or we maybe it was such and such thing, etc. But should we be more careful in evaluating or diagnosing a patient based on core biopsy at times? Because generally speaking, we do not do renal core biopsies in renal cell carcinoma if it is, most of the times, in the past, they have been undergoing surgeries mostly. So, and the pathologists are very well versed with the, seeing the whole kidney and diagnosing it. And these other types of tumors are very common there.
Yeah, Dr. Mudassir, because it's a young patient, IHC was definitely done. Without IHC, we would not start any systemic therapy for a young patient, because it's known that these patients may sometimes have a rare tumor which could be, there. So IHC was done, and that's what I was mentioning before, that our pathologists went back to reviewing both the histopathology and IHC, and they still can't say that no, that diagnosis was wrong, because it was not wrong. So yeah, and
I agree with you completely. I agree with you, ma'am, completely. What I mean to say is, that that sometimes we may not actually be very sure, because I'm guilty of myself when we see some pathologists writing on biopsy that it is a clear cell carcinoma, I would not actually think, again, is it something else?
Yes. So and the other case. Yeah, that's the reason we got in this case, and the patient now is doing really well. So yeah, so touch wood, he's doing really well, and that was the key message, that sometimes, once in a while you get such shocks, or you see something which is so rare, and we'll definitely come out with something published on this.
I think so. I think so.
Yeah, yeah.
And
So
I think both
actually, sir, I have two more. There are two more very clinically important questions in this patient. So in this patient, after the initial treatment, there was differential response. There was like response in the lungs, but there was progression in the kidney. So obviously, we have to, in such a case, if the patient is still not able to go for surgery, we have to actually go for another biopsy in this case, probably.
Right.
The other question is in cases of, for example, let us say we are still thinking that it is an RCC, it's a clear cell RCC, and we are saying that it is like progressing in the kidneys and elsewhere it has responded well. Then also we have to go for surgery because there is a role of surgery after the initial systemic therapy as well, especially in RCC.
Yeah, yes. Dr. Mudassir, what you have pointed out is true. That's what me and Dr. Shruti was trying to say, is that this patient had a mixed response. So mixed response, and particularly a large mass with pulmonary mets, large nodes seen on imaging. It was very unlikely and unacceptable to have those nodes, huge nodes, to be just free of any metastatic focus over there. Had this patient, after initial treatment, when showed a progression in the primary, and had he not been fit for surgical resection even at that point of time, obviously it would have been doing biopsy again. Maybe that point we would have asked our radiology colleagues to do not biopsy from one area, but from multiple areas in the same kidney.
Agreed.
Or a PET-guided biopsy from the sites of progression. So that is also, we have done it for a couple of patients. Many a times that PET, if it is showing a mixed response, we do a PET-guided biopsy. So that is also very helpful in such situations.
Right.
I just want to share one thing, Dr. That is, I think whenever we are confirming the diagnosis, this is the RCC, we should confirm with the ISC with this RCC, which type of RCC, clear cell RCC or papillary RCC or comophobe RCC or sarcomatous, because every type has different type of prognosis. Every type has different drugs to respond. So I think when we confirm the RCC, we should go further for the, is that papillary or is that clear cell or chromophobe or whatever the types are we are getting.
Yeah, right.
It will guide us for the next treatment.
Right. I think many a times what happens, those patients who come up for surgical resection or who are for surgical candidates, usually the IHC is done after the final histopathology when the entire kidney is subjected. At the time of a core biopsy and where we are planning a definitive treatment, unless it is metastatic. If a patient is metastatic where we are not planning a surgical resection, then doing a IHC is worthwhile and accepted. But if you are planning for a surgical resection for a patient, then doing an IHC upfront on a core biopsy, I don't think would be the right choice. It would be better to do the submit the entire specimen and get an IHC done on that.
I agree with you. But in that case, in the particular the case 3, that is the diagnosis came out with the PNET, that is sarcoma.
Right.
So in case of the sarcoma, soft tissue sarcoma, there is a role of, the neoadjuvant therapy, because the neoadjuvant therapy, if the patient having the neoadjuvant therapy and got the surgery, and you will get the more benefited from the surgery. There is the same thing is happening in this patient, because the patients getting the, whatever the drugs he is taking, but these act as a neoadjuvant therapy, the lenvatinib and the everolimus. So the patient getting the neoadjuvant therapy and got the surgery, and I think definitely he will get the benefit from all those type of the modalities of treatment.
Dr. Rafiq, I would just like to ask you one. Dr. Rafiq, I would just like to ask you a question. How many cases of primary PNET of the kidney have you seen?
It's very rare. We do in my it's very much right. But we are talking, the academic session. That's why I'm just raising that question, right?
No, in fact, as I mentioned, both you and me, we follow in the same sheet. How many of our patients, honestly speaking, we would be able to advise and get IHC done from core biopsy at day 1. Although hypothetically, it should be the ideal way. Okay, good. Okay, moving on to the, thank you. That was a wonderful discussion, and it was a case I particularly put over there. I know there was some twist and there was certain learning curve in this particular patient, but it was necessary to insight this, have all the insights from such wonderful panelists over here. Moving on to the fourth case, we have a 59 years old gentleman, ECOG status 2, who presented with history of cough, breathlessness, and weakness since 1 month. He had shortness of breath since 3 days and loss of appetite with weight loss. No history of any abdominal complaints. And clinically, there was pallor. RS showed a reduced air entry on the left side. A mass was palpable in the right lumbar region. Liver and spleen were not palpable and no ascites. There was a right varicocele which was clinically noticed. CBC showed a low hemoglobin and elevated LDH. A CT thorax which was done showed bilateral pleural effusion, left side more than right, and there were multiple bilateral lung nodules suggestive of metastasis. Since he was symptomatic for breathlessness, ICD was put, and fluid which was sent for cytology was reported as positive for malignancy. So PET scan showed a large mass involving the right kidney and infiltration into the renal vein, not going into the IVC, and there was bilateral lung nodules with pleural effusion. So we are talking about stage 4 CA RCC with skeletal mets also. These were the PET CT scan findings. Biopsy was done, which turned out to be a renal cell carcinoma, clear he's talking the least, and I think next time he's not going to invite me to Nepal if I don't get him on the board over here.
Yes, sir. Did you ask me?
Yes, sir. Pankaj Saab, boliye.
Yeah. So I think this is a clear-cut case of renal cell carcinoma with lung mets and pleural effusion as well as bone metastasis. So biopsy showing, clear cell RCC. So we need to, prognosticate. We need to stratify the patient first into good risk, intermediate risk, or poor risk. And, based on that, we should offer this patient a combination of TKIs and immunotherapy.
Okay. Anything else you would suggest, you would advise a NGS over here at this stage? Dr. Shruti initially mentioned that NGS, though it's not changing the clinical profile now, but still while starting, he's 59 years old.
Theoretically, yes, I would say if the patient is affording, then definitely I'd like to do a NGS because we can find other, biomarker which can guide or which can predict further treatment in this patient.
Okay. Any role of cytoreductive surgery over here in this particular patient upfront?
Not upfront, maybe. Upfront, not upfront surgery because of pleural effusion and multiple lung nodules with bone mets, not upfront cytoreductive surgery.
Okay. Dr. Barman, as you mentioned that for you, the option would be a IO along with the TKI. But based on the first-line therapy options for clear cell histology and the subsequent therapy options, we have a huge cafeteria-like approach available. So may I, you mentioned IO, and I'm sure every medical oncologist offering the best treatment to your patient is the primary goal. But if you have a patient who is not affording, what would be the other options you would give?
Combination of TKIs, maybe, if the patient can again afford lenvatinib or along with mTOR inhibitor, or maybe just pazopanib or sunitinib. Okay. Those are actually good drugs which we're using for so many years. Pembrolizumab and other immunotherapies, these are recent drugs, but sunitinib, monotherapy or pazopanib monotherapy was very effective until recently.
Okay. With your experience of IOs and using pazo or sunitinib, if I have to, what is the percentage of patients you have seen who have responded extremely well to these IOs or only to the pazo or sunitinib arm?
As I said, for so many years, we used sunitinib and pazopanib. Those patients did extremely well. IOs until recently we are using IOs. Till last 1 year, maybe I have used in 7-8 patients. And most of them, they did well, actually. Most of them, almost 80-90% of them, they did well.
Okay, okay, right. So this particular patient also we discussed in the MDT, and we gave him an option of IO and other options available. But unfortunately, because of financial constraints, the patient opted to take pazopanib because that was available in a clinical trial study with us. And patient received pazopanib for 3 months, and at the end of 3 months, a PET scan was done, which showed reduction in the metabolic activity of the primary lesion. There was resolution of retroperitoneal nodes, resolution of the FDG-avid lesion in the lower pole of left kidney, the resolution of adrenal lesion, and both the skeletal lesion as well as the pleuropulmonary nodules had shown an excellent response at this particular stage. This was the pre-treatment scan and the post-treatment imaging, which clearly shows regression in the size of the lesion, along with regression in the lung nodules and regression in the skeletal lesions as well. So at 3 months, this is a say patient's general condition has improved. He's showing a regression in his majority of the lesions. What would be the advice you would give to the patient?
Just continue with pazopanib along with one of the bone modifying agent, yes, until he progresses.
Okay, okay, fine. After he progresses, and what would be the other options available to you?
Again, if the patient cannot afford immunotherapy, then one of the other TKIs, maybe cabozantinib or lenvatinib.
Okay, okay. Thank you, Dr. Pankaj. Dr. Makhsud, Dr. Rafiq, Dr. Nicasio, anyone else wants to add something over here? Dr. Shruti or Dr. Moderator?
I just want to add something. Again, from the very first case, I just mentioned that there is some scoring system, like in case of the advanced RCC, we have IMDC scoring system. So if we have the IMDC scoring, there is 6 tiers: performance status, hemoglobin level, calcium level, platelet, neutrophil level, and the time from the diagnosis to treatment less than 1 year. If the patient having the score 0, the survival 43 to months. And if they score 1 to 2, then survival became half, that is 22.5 months. And the score is 3 to 6, that is 7.8 months. So if we have the patient of the performance 2 and very much aggressive and advanced stage, so if we can categorize the patient, we can visualize the the prognosis of the disease. So according to the prognosis of the disease, we can choose the drugs, because in case of the metastatic RCC, the survival or the prognosis, if the patient having the highest score, the prognosis average mean survival is only 7.8 months. So in our context, if the patient having the 7.8 months and we are spending a lot of money on the IOs, there's a very, in my context, in my country, this is not possible. And the evaluation of the TKIs, first of all, we treated the patient with the, the interferon, that is IFN. Then the TKI is coming to the market. And first TKI is the sunitinib, then pazopanib, and right now this is cabozantinib. After that, the IOs, that is immunotherapy. Still there is some, the resource constraint like the Bangladesh, I know whatever the Philippines situation, I don't know the situation of these other countries, but in my country, still we are very much, confined to the TKIs like the sunitinib, pazopanib, and the the cabozantinib. You are asking lastly, what are the next when the patient is recurrence? So there is some, the trials like, COMPASS trials, they compared to the non-inferior trials to the pazopanib and the sunitinib. So pazopanib, if the patient getting the pazopanib and having the recurrence, we can switch to the sunitinib. This is the trial that they are supporting. And there is another switch to trials. They are comparing to the, the TKIs to TKI, like, sorafenib to pazopanib, and then pazopanib to sorafenib. So both are the getting the survival benefit, overall survival, even the progression-free survival. So first choosing the TKIs, we must categorize the patient. If the patient having the intermediate risk group or high risk group, if patient having the high risk group, we go for the immunotherapy because it will the survival the most among the
Right.
all TKIs and the options available. Immunotherapy with the TKIs survival is the most.
Yeah.
If patient can the avail the cost. If
Yeah.
not, in that case, we have the limited options for the only TKIs.
Right. Thank you, Dr. Rafiq. And that was wonderful, elaborating all the various options available. I think we have overshot our timelines by 3 or 4 minutes. I would give over all the proceedings to Dr. Vidya now. Thank you for base for this opportunity. And Dr. Vidya, can you please take the things forward?
Yes, sir. We have a few questions. Some of them were already answered during the sessions, but I will quickly walk through all the questions and you can give your opinion on this one, sir. Does different subtypes have different prognostic relevance in renal cell carcinoma? Is there any role of CGP? So essentially the pie chart that you discussed in the beginning.
Yeah, it's already there.
So there you have mentioned about the 50 to 60% overall survival in clear cell category, whereas the papillary 1 and 2 have a slightly better overall survival. And the other, subgroups have much better survival. So, so when the overall survival at the end of 5 years is only 50 to 60%, doing molecular testing upfront, does it help in taking informed clinical decisions at the time of diagnosis in clear cell carcinoma? I mean, predominantly you have mentioned curative surgery is the primary option in most of the patients, but when they present metastatic setting, doing a CGP upfront, will it help you in taking better decisions for the chemo combinations or definitely standard of care guidelines does not recommend any biomarker.
Yes. So,
right.
Obviously, there is no role. But then,
no role.
Based on just your experience,
Yeah.
I'd like to add to that. It can definitely help screen families that would be at risk for RCC in the future. So it has its use also.
Okay. Any other suggestions?
So I just want to add one thing, that is in case of the RCC, the 70% patient having the VHL mutation. And the PVR M1 is 41%, BAP M1 is the 15%, and ACTD2 the 19%. So those are the mutation are the responsible or the etiology behind the RCC. But this mutation is not will guide us or the benefit the patient for the taking the treatment or the other options. So if patient having this type of the mutation, we can just taking the advantages. Okay, fine, we know the mutations, but I don't know, still there is no NCCN or there is no ISMO guideline to prerequisite for the molecular testing for the RCC treatment.
Agreed. And most of the tyrosine kinase inhibitors are pan kinase inhibitors, multi-targeted kinase inhibitors.
Yes.
So the specificity is not there.
Yes.
So that is the biggest challenge. Yes, Dr. Shruti, you want to add something?
No, I'm so sorry. Okay. Please go on.
Yeah. So that we know. And then definitely although VEGFR inhibitors are available for several decades now, multi-kinase inhibitors starting from imatinib, sunitinib and all, there is no, way back in BCR-ABL, we knew that there is a lock and key mechanism for imatinib. Following that, sunitinib is again, it binds to multiple pockets of different proteins. So definitely that 50 to 60% what we see as overall survival, by doing molecular genetics at the clinical trial level, can we push the boundaries to improve the outcome in these patients? Are there clinical trials where such an adoption is there? I mean, even in clinical trials, I see mostly these multi-kinase inhibitors plus other targeted therapy options are there. But we would like to hear from you and your experience, like Were there any isolated incidences or where there is a role in terms of looking for any signatures or protein expression patterns where CGP can be applied? But because it turns out RCC, clear cell carcinoma, turns out to be the largest in subgroups, among the subgroups
Yep.
in terms of
Yes.
their incidence, right? Sir, when you do early stage disease resection, their survival is very good, right? I mean, if
Yes.
Yeah.
it is N0, M0, they survive more than 10 years.
Yeah, I think most of the, if
Uh,
the as I mentioned initially, as compared to a lung or a pancreas or a gallbladder, definitely RCC the survival is better, and fortunately, quite a few of them do present in an early stage, where it's either localized to the kidney or to the nodes. So then the survival is good. Once they cross the 5 years, the chances of relapse actually go down significantly.
I just want to add, Dr. Raj, that is, if the patient is categorized as a low risk groups, the 5-year survival is 97.1%. This is a very good percentage, 97.1%. This is a very good percentage to have the 5-year survival if the patient having the low risk group. If the patient having fall into the intermediate risk group, that is 73.8%. So everything is depends on the patient's status during first time of the diagnosis, when the patient having meet with the physicians, what the status of the scoring system of the, and what is the histology types of the. So three tiers should be considered. What is the staging at the time of the diagnosis? What is the histopathology time of the diagnosis, and the scoring system? So these things will guide us the prognosis and the survival rate of the patient.
Right.
Okay. So unlike lung cancer, which is a silent killer where presentation itself is mostly metastatic, in renal cell carcinoma, there is a symptomatic clinical symptoms are much early in early stage of the disease. So that is probably helping these patients to get a cure for most of them, right?
Right.
So
Right.
I think that's the kind of a take home for a scientist to understand.
Yeah.
Yes.
In,
And yes, sir.
in fact, of late, we are seeing a good number of patients with bilateral renal cell carcinomas also. Either they present as synchronous primaries, or a patient who has been operated earlier in one side and now develops a second primary in the opposite kidney. I have operated almost 3 patients. One patient I'll be operating next week, where RCC on mass on one side and opposite kidney also. Fortunately, that was a lower pole lesion, so where I can do a nephrectomy on one side and do a partial nephrectomy on the opposite side. So I don't know whether there are changes in the epidemiological factors or some genetic pathways are triggering, but we have to keep in mind, and there are instances of such challenging surgical scenarios and young patients where we are talking about bilateral malignancies also.
I just want to add one more, but it might look very vague to ask, but you also mentioned analgesics is one of the important, factors
Causative factors,
associated,
epidemiology.
causative factors. So acetaminophen, paracetamol is something which is taken day in and day out by multiple. So how was the history? Have you come across whenever you have assessed patients? Did you see that these patients had a severe history of taking painkillers for decades or something like that?
See, along with painkillers, I think the another major causative factor, we will not be able to pinpoint it or actually put it on record. I'm not sure, but consumption of large amount of these Ayurvedic medications or alternative therapies also have some role in it. Alternative therapies also have some role.
And chronic kidney disease also, for many patients we've seen chronic kidney disease later developing RCC.
So,
Ayurvedic. Yes,
Dr. Raj is talking about the alternative medicine. This is very common practice in our subcontinent. So it's also bound the patient, because the cost of the treatment, the most of the patient are unable to bear the cost. So they are always looking for the cheap options. So Ayurvedic and the homeopathy and these other alternative medicine, they are all cheap options. So their marketing is very strong, and the people are there just running to this Ayurvedic shops, to Kobiraji shops, to the homeopathy shops to get the medicine because it is very cheap. So we don't know because we are not an Ayurvedic physician or the homeopathy physician. But I read some papers on that thing. The Ayurvedic have some component. This is very much triggering the some mutating options, some mutating point to build up the carcinogenesis. I don't know. I'm not the expert of that thing, but I read some papers on that. So in my arena, in my country, we have we have done some studies, research. How many people taking the alternative medicine? This is the result was shocking. 56% patient taking the alternative medicine besides the definitive treatment of the cancer treatment. Can you believe this?
Okay.
I don't know.
But I think that must be a similar scenario.
Yes.
Yeah. In India also, there is quite a few places where they provide alternative treatment, right?
Yes.
Even as part of.
So, but I think, Dr. Rafiq, the reason is that you are mentioning about 97% response and 7.8 months of median survival and all these things with the IO therapies, which is going to cost about 3 lakh rupees per month. Ayurvedic practitioner gives 100% response at 10 or maybe a few hundred or 1,000 rupees. So that's the difference.
Right. And besides that, their marketing policy is very strong. There's some, some persons they're marketing. Okay, fine. I will give the 100%. Security will get the free of the disease within 3 months or 6 months.
Okay. Right.
So there is nice to meet you, Dr. Raj.
Same here. It was a pleasure having all of you all on this panel, and it was wonderful. For me, it was a learning curve also, understanding what are the new things going on, though, because most of our things, as when it comes to the non-surgical part, my colleague Dr. Shruti and her team, they take care of it. But it was heightening in one way that, as I mentioned at the beginning only, that beyond the borders, most of us, when it comes to our patient care and the type of patients, the type of challenges we face, they are same across.
Same. Yes, you're right. You're very much right. So
There's one question. There's one question here for the medical oncologist. Yeah. So have you ever come across resistance to VEGF inhibitor therapy?
Definitely. We are facing these things every day because the patient getting the pazopanib, then still getting the pazopanib, the patient, theoretically the disease should be, size should be decreased. But the practical scenario is different. After taking 2 months pazopanib or 2 months cabozantinib, the patient having more disease progressive. Because we know the cancer cell resistance system is different. Because the cancer cell proliferation, maturation, everything depends on so many pathways. So we are only able to less than 2% targetable pathways to target this pathway. But rest of 98% targetable pathways are open for the bypass the drug system. So cancer cell is it has its own protective mechanism to bypass this mTOR pathway. Like we are giving the prescription with mTOR pathway inhibitor like, everolimus. But the cancer cell definitely very easily bypass the mTOR pathway. So then they become very resistant. But fortunately, the average time of the, if the diagnosis is correct, if the histopathology and IST is correct, the drug has some rules, some in respect of the progression-free survival and overall survival. So according to the trial, according to the result, we are getting at least 6 to 9 months good result with the drugs. After 6 to 9 months, in my personal experiences, after 6 to 9 months, we are getting the results resistance. After 3 months, 6 months, 9 months, they are getting come back to the outdoor department, having the disease progression. So the NGS and other investigations is not available in my countries, and the patient's capacity is very limited in our limited resources countries. So we are most of the time we are unable to recheck the biopsy, recheck the further investigation. So we are usually switch the drug whatever he or she is taking as a first line. If the patient taking the sunitinib, we go for the pazopanib. If the patient taking the pazopanib, we go for the cabozantinib. So we don't have any available and cheap option to focus on the recurrence mechanism by which you can target this mechanism. This is not available option in my country. So we are following the switching therapy like sunitinib, then pazopanib, then cabozantinib, then everolimus, like that way.
Okay. Yeah.
Okay.
Thank you so much, all of
Thank
you,
you, sir.
for
Thank you. Thank you very
this
much.
discussion, and
Okay.
have a nice time.